few presentations such as this. Can everybody see the slides okay? Can we just assume that?
Martin, can you see the slides?
I just muted you.
Martin, can you see the slides?
Yes, I hear you. Thanks, Guy.
Okay, great. So, yeah, what I wanted to do to talk to you today is about the transition and some of the work that we've been doing, looking at the physiology of transition and birth. And I know many of you think, well, you know, we knew this years ago, but I think there's the new information that's coming available as to how this information that actually impacts on how you manage your practices clinically. So, just to start with, I have nothing to declare. When I often asked to talk about the transition to independent life after birth, usually somebody asks me to talk about one or the other of the two major transitions that we know about. And often it's viewed that these two transitional processes occur independently. And I'm either asked to talk about the respiratory transition or the cardiovascular transition separately. But the point that I'd really like to make today, and the overall arching, I suppose, view of what I'm trying to get across, is that these two things are not independent. They're very much interconnected. With the respiratory transition, which is the primary trigger, it's driving the cardiovascular transition of birth. And it's predominantly driving it by stimulating an increase in pulmonary blood flow. Now, of those two transitions, particularly respiratory and the cardiovascular transition, the respiratory transition is affected by labour and birth, and the cardiovascular transition, we now understand, is actually quite dramatically influenced by umbilical cord clamping. So what I'm going to do is talk about each of these processes in turn, and I'm going to start with the respiratory transition and how labour and birth can affect this. And of course, when I'm talking about respiratory transition, I'm predominantly talking about how the airways are cleared of liquid at birth, but also what is the functional effects of this airway liquid clearance, and particularly with regard to how you ventilate an infant at birth, particularly a preterm infant. And in essence, what we're talking about, so once you're born, you will have liquid in the lungs, and how much liquid you have will obviously vary. But that liquid must pass down through the airways down into the tissue. So that's cleared out of the airways into the tissue. And then it's in the tissue for a period of hours, and before it's actually cleared out of the tissue. So what we're actually looking at is that lung aeration at birth is really a three-stage process. The first stage is when we have liquid-filled airways, and so the big problem there is actually moving liquid versus air through the airways, and of course liquid's got a higher viscosity than air, so it's going to have a higher resistance. Not a very long period or duration of this phase, could last between 30 seconds to 5 minutes. The second phase, which does have an effect on the mechanical performance of the lung, is what is the effect of having liquid in the tissue? Now, from some research, the time frame for the liquid being cleared out of the tissue, we're talking around about 4 hours. So this is a much longer phase than the first phase. The third phase is clearance of lung liquid from once it's cleared from the tissue. Now the focus can predominantly be on blood gas and respiratory gas homeostasis in terms of aerating or ventilating the lung. So what I want to do is talk about, first off, is how do we clear the airway out of the liquid, so clear the airways of liquid at birth. In essence, when you look at the literature, there's actually 3 proposed mechanisms. The first one is where you have posture-induced increases in transpulmonary pressure. So this is largely where the fetus is, as it's passing through the cervix and vagina, is forced into a sort of a dorsoventrally flexed position, And this increases abdominal pressure and thoracic pressure and explains a lot of the gushes of liquid that has been seen and reported in the literature coming out of the nose and mouth. So that is clearly one mechanism, and of course probably won't be active in infants that are born by cesarean section. The second mechanism, which is by far the best well-known mechanism, is sodium reabsorption and the effect of reversing the osmotic gradient across the pulmonary epithelium. And I just wanted to talk a little bit more about that because it basically, if you ask many neonatologists, well, what's the mechanism of airway liquid clearance at birth? They'll say, well, that's easy, it's sodium reabsorption. And really, there's not a great in-depth understanding of how this process works. So I just wanted to show you the schematic of how the proposed mechanism for airway liquid clearance. So if you look at over here, they'll see the arrow, right? So here's the lung lumen, and separated by the lung lumen from the tissue is the epithelial cells. It's quite a tight barrier, and it's proposed that adrenaline, due to the stress of labour, binds to beta receptors, stimulates cyclic AMP, and in so doing activates epithelial sodium channels, allowing sodium to move into the cell. The then increase in sodium concentration inside the cell activates the sodium-potassium ATPase, which then pumps sodium out of the cell for each potassium ion, 2 potassium ions, and this creates an osmotic gradient due to the net movement of sodium from the lung lumen to the tissue for water to move. But look down here, the maximum rate is 7 to 10 mils per hour per kilo. And I'd like you to actually fix your mind on this number here, because that's really quite slow. So it's too slow, really, to be responsible for them being the major mechanism for clearing airway liquid. Adrenaline must be elevated for hours to clear all of this liquid at this maximum rate. It's not active, of course, in preterm infants. So how do preterm infants clear the airways of liquid? And in the experimental studies, we can show that you can clear the airways of liquid in exactly the same way in a live animal. You can do it in a dead animal up to at least 2 hours after death. So clearly, you can clear airway liquid without the animal being alive and sodium reabsorption being active. So what I want to do is convince you that the predominant mechanism at birth or after birth is an increase in transepithelial pressure. And to look at this, we've been using a technique called phase contrast X-ray imaging. And just to briefly describe what this technique is what I'm showing you here on the left is a X-ray of a bubble in water. And you can see the bubble here because there's a lighter region, and X-ray or air absorbs X-rays less than the surrounding water, so you see a light region here. And as soon as you use the technique of phase contrast, this is what the bubble looks like. So now you still have a lighter region in the middle where it's predominantly air, but now what we've done is resolve the boundaries between the air and the water, and this is because this technique, the contrast in this instance, is being produced by the air-liquid interface. So when we look at a fetal lung, because the fetal lungs are liquid-filled, you can't see them, so there's no phase contrast. But as soon as the lung aerates, you can quite clearly see the trachea and the major bronchi, and you can see quite a lot of detail in the lung tissue here. And you can even see a few bubbles down here in the newborn stomach. We can blow up a region here and look at the resolution that we can get. And here you're looking at down here when you have a single airway in propagation, you can see this can resolve individual single alveoli. So this is the only technique that I know that has the resolution of being able to see in situ single alveoli. So what we do is actually image them as they go from this state to that state and observe how liquid enters the lung. And at the same time, we have them, these are rabbit pups, we have them in a plethysmograph, and we can measure, so these are spontaneous breaths here. We can measure the increase in gas volume in the lung with each spontaneous breath. And you can take an image at just before the breath, and this is how much air is in the lung. There's a little bit in there. You can take an image at this point immediately after the breath, and you can see how much, just in that single breath, how much air has entered the lung. And when you do the maths, you can see that we're clearing around about 7 mils per kilogram in 1 second. And so the actual lung liquid clearance rates here calculate out to be around about 25 litres per hour, not mils per hour, but litres per hour per kilogram. So the other point that I wanted you to note is, look at the time frame. So this is a term rabbit pup, and it's basically aerated its lungs in 35 seconds or in about 5 to 6 breaths. So it's extremely rapid. And of course, this is what you see in term infants. They take a few breaths, they become very pink, and away they go. So we think this is the predominant mechanism. And basically what's happening is that you have an air liquid filled lung. There's an inspiration which generates a pressure gradient between the tissue and the airways. And as a result of that, liquid moves out of the airways into the tissue. And then with each subsequent breath, more liquid leaves the airways, enters the tissue until you completely aerate the lung. So in this instance, it sort of makes sense that inspiration is predominantly driving airway liquid movement out of the airways. So what are the implications of this? Well, what it does is it tells us that by generating a transpulmonary pressure gradient, then you can clear the lungs of liquid. So if we go, and I apologise for the simplicity of this, but if we go back to ventilation as the basics, why do we have inspiration? Well, we have inspiration to get oxygen through the airways down to the main gas exchange regions of the lung. Why do we have expiration? Well, we expire to get rid of the carbon dioxide. But when the gas exchange regions are liquid filled, there's going to be no gas exchange. And so you can actually make 2 points out of this. The first point being, well, there's no real reason for expiration because there's no gas exchange, so there's no CO2 to clear. The second point is that, well, as soon as you start seeing CO2 in the expired gas, well then that's a really good indicator for when you do have aeration of the terminal gas exchange regions of the lung, and therefore you are getting gas exchange from occurring. But going back to the first point, if there's no gas exchange, you don't need expiration, so why not then do a sustained inflation? And this is what a sustained looks like when you do it at the synchrotron. Here you can see that it gradually air accumulates in the lungs. It's not homogeneous to start with, but the real point here is that by the end of the sustained inflation, the lung is beautifully and homogeneously aerated, and it doesn't keep expanding. Once it reaches the pressure and the volume and it's aerated, it doesn't continue to expand. And then almost immediately from the first tidal breath, you get homogeneous ventilation of the lung. So in that instance, for clearing the airways of liquid, and I think it's important to mention that they were intubated animals, and so the evidence at the moment for doing sustained inflation from the animal studies is all about in intubated animals, and at the end we can actually talk about what's the impact of actually giving a sustained inflation via a face mask in a non-intubated infant, and we can talk about that later. Because now what I want to do is to move on to what is the effect of having the liquid in the tissue, and because it will change the properties of the lung and the potential for airway liquid reflooding. If you move, and this is sort of an interesting concept, if you actually move the water out of the airways into the tissue, because the tissue has a finite volume, the pressure has to increase. And there is an Italian guy who's reported this, Miserocchi, and has measured interstitial tissue pressures in situ in rabbits, and he showed that from birth, immediately after birth, there's an increase in interstitial tissue pressure which lasts for about 4 hours, until then eventually probably the liquid is cleared, and then the interstitial pressure goes subatmospheric, where it remains for the remainder of our lives when the lungs at rest. This increase in pressure is most likely due to the accumulation of water in the tissue, so it really does have a physiological effect. We actually see this with the phase contrast imaging, and we actually didn't hypothesize this. We thought, well, as soon as the lung aerates, because you're generating recoil pressure, the actual chest wall should collapse. But what we found is that the physicist who actually was doing the analysis for us rang me up and he said, oh, why does the chest wall expand after birth? And my response was, well, actually, no, it doesn't. It actually should retract. And they said, oh, no, it doesn't. And being a physicist, what he did was, if you look at the X-ray image here, what you're looking at is a composite of two images. The first image was at the start of before lung aeration, and in this instance, the ribs are in white. And then the second image is after lung aeration, and the ribs here are in black. And you can see how the process of lung aeration has caused the chest wall to expand. And when I thought about it some more, I thought, well, actually, this makes perfect sense, because what you're doing is, because during lung aeration, you're increasing the volume of the chest by the amount of air that goes in, or the FRC, and since the water isn't leaving, then the thoracic volume has to increase. So this makes a lot of sense. Actually, when I mentioned this to one of my clinical colleagues, he turned around and he said, oh, isn't nature wonderful? That's the reason why you're born with a compliant chest wall. And of course that makes a lot of sense. If you're actually born with a stiff chest wall, when you're reabsorbing the lung liquid, the actual increase in pressure, interstitial pressure that would occur, would be much greater, and therefore there's a risk of liquid re-entering into the airway. And of course, how do you deal with that? Well, you apply pressure into the airways to prevent that from occurring. And of course, these are the PEEP videos that we demonstrated when we were looking at the effect of PEEP on lung aeration at birth. And what you see here on the left is that here's ventilation of a preterm rabbit pup with an end expiratory pressure. And on the right here, and this is what happens when you ventilate a preterm rabbit pup without an end expiratory pressure. And what you see is that during expiration, water is moving, or the airways are collapsing, one or the other, and pushing the water back down into the larger airways as a result. But most importantly, there's no really accumulation of gas volume in the lung as opposed to what happened if you give PEEP. So that's and again, I emphasise the point, this is in an intubated animal model that's being mechanically ventilated. So of course, nature being nature, there's lots of variability, and there are obviously going to be times when there's infants born with not much liquid in their airways, and maybe these are the infants that are born vaginally, and as a result of that, not much liquid's going to be going into the tissue, and so there's going to be a minimal increase in interstitial tissue pressure. But likewise, there's going to be infants that's born with a lot of liquid in their airways, and so all of this liquid has to go into the tissue. And so likely there's going to be a group of infants that are going to have high interstitial tissue pressures. And what I'd like to propose to you is that maybe these infants are the infants that are born by caesarean section. They have more liquid in their tissue, so they're dealing with more liquid in their lungs. And so what's the effect of increased volumes of liquid in the airways? Well, really scientifically, we would hypothesise that they should decrease FRC, decrease lung compliance, and increase airway resistance, and indeed that's what happens. So we looked at this at 3 different ages. So these are very immature rabbit pups. These are sort of slightly less, and these are closer to term, but still preterm by a couple of days. And you can see that with increasing age, the effect of having liquid, more liquid in the airways, which is in blue, has quite a significant marked effect on FRC accumulation, has a marked effect on the peak inspiratory pressure required to generate a tidal volume of 8 mils per kilogram at 3 minutes. And if you look at airway resistance, you see that it also has quite a marked effect on airway resistance. The very interesting point here is that the very, very pretermers actually didn't have much of an effect of having more liquid, which is sort of hypothetically quite interesting, and it's something that we could talk about later if you would like to. So, in terms of the airway liquid clearance and the respiratory transition at birth, airway liquid clearance predominantly at birth results from pressure gradients generated by inspirations or inflations. Airway is then cleared into the perialveolar tissue, which increases tissue pressures and the potential for liquid to re-enter the airways. And larger airway liquid volumes increase the potential for liquid to re-enter the airways, which has an impact on respiratory function after birth. What I want to now is quickly move on to is respiratory transition and how particularly how this the cardiovascular transition and how this is triggered by the respiratory transition and the increase in pulmonary blood flow. And then there's absolutely no doubt, we've known for years, that lung aeration is what triggers the increase in pulmonary blood flow at birth. And this is probably one of the most remarkable things that occurs in nature is the increase in pulmonary blood flow at birth. It's really quite remarkable. You can look here, so these are pulmonary blood flow measurements in sheep, fetal sheep. This is before cord occlusion. You can occlude the umbilical cord, not much happens. It's after you start ventilation that you get this massive increase in pulmonary blood flow. So this is a 25-fold increase in pulmonary blood flow, a 20-fold increase. Okay, so we know that it's all about getting air into the lungs. So if you look at the literature, well, what primarily is responsible for the decrease in pulmonary vascular resistance at birth, and you know the traditional theories on this, and most of the research shows that it's either oxygen or a combination of all of these effects, an increase in shear stress within blood vessels, which activates vasodilatory responses, in particular nitric oxide, prostaglandins, and clearly-1 ion channels, and also an increase in lung recoil. What all of these mechanisms have in common is that they should work locally, in that lung aeration and an increase in pulmonary blood flow should be spatially related. And of course, we know this from the adult literature that what we're talking about here is ventilation perfusion matching. So we thought, oh, well, wouldn't it be really cool if we went back and did simultaneous phase contrast X-ray imaging and angiography? But in this instance, what we should do is just ventilate one part of the lung. So what I'm going to do is show you a movie where we inject iodine into the lung to show what happens to pulmonary blood flow, and then we start ventilating just this region of the lung down here, and I'll show you now what happens. So here's the first iodine injection. Very little, as we know, very little blood flow into the lungs. We start ventilating just this region down here. We assumed all the increase in blood flow would occur down here, but lo and behold, it actually increased to both sides of the lung equally. Just to show you again, is the blood flow during in the fetus, very low. Ventilate this part of the lung. Big increase in blood flow to this part of the lung. One more time, just so very little blood flow, ventilate this part. Big increase in blood flow to both sides. So we can look at this, and when I say we, it's a royal we, so a PhD student's gone through each of the images, and what he's done is he's measured internal diameter, so what happens to the vasodilation. So here, even though there's small changes in diameter, there's big changes in resistance. Okay, we can do pseudo measures of flow, and you can see this is where you no ventilation of the lung, we ventilate one small part of the lung, big increase in pulmonary blood flow in both sides, doesn't matter which side we ventilate, and then this is what happens when we ventilate both sides. So when we went to publish this, of course, we thought, well, we're actually probably looking at a mechanism that is independent of this spatially related effect, and particularly that's independent of oxygen. And of course, the reviewers didn't like this. They said what was happening was where you're aerating this part of the lung here, and the oxygenated blood is going over to the other side and is vasodilating that region, the unaerated region of the lung as well. So to look at this, we actually decided to repeat this experiment, but this time we ventilated in air, 100% nitrogen and 100% oxygen. And lo and behold, so we then, this is pulmonary blood flow, no aeration, so this is where we just aerated one lung with nitrogen, got exactly the same response. So 100% nitrogen, got exactly the same response. Here's the air, so a little bit of oxygen. There is an oxygen-related effect as well, but you can see there's a large part of the response which is independent of oxygen. Interestingly, we were also measuring ECGs, so this is probably something that would be familiar to most of you, where you start ventilating at birth, so this is airway pressure, this is the tidal volume, you start accumulating gas in the lungs, and as soon as you do, this is an ECG here, you increase heart rate. Okay, so here's the increase in heart rate you would normally see in a ventilated infant. This is in a rabbit pup. But the interesting thing is these pups were ventilated with 100% nitrogen. So what's going on here? This is sort of a bit of a surprise to us, that you could get an increase in heart rate without any oxygen. So what we're looking at is here is we think is that there's an increase in left ventricular preload, which increases pulmonary blood flow. So that's a perfect introduction to where I want to go. So lung aeration causes an increase in pulmonary blood flow that is enhanced but not dependent upon oxygen. It's not spatially related, which causes a large ventilation-perfusion mismatch. Now, we're actually taught to believe that this is a bad thing, a large ventilation-perfusion mismatch. But I'm not quite sure that that's the case. I think this could be a good thing, because what I'm just about to describe to you is that this story goes on, and this story is about actually providing the left ventricle with preload. And so in so doing, since pulmonary blood flow becomes the major source of preload for the left ventricle after birth, you don't want the provision of that preload completely dependent on all of the lung aerating. Okay, so I think it's probably maybe a good thing in this instance. So now what I'm going to do is finish up and tell you about how this increase in pulmonary blood flow affects the cardiovascular transition, or drives the cardiovascular transition, and what's the impact of umbilical cord clamping. And as I mentioned, this story is all predominantly about venous return. So here I have these two schematics here. We're looking about the circulation of the newborn and adult. And it's very simple compared to the fetus. All blood returns to the right side of the heart, all goes through the lungs, and all back to the left side of the heart. So the left heart, all of the preload comes from pulmonary blood flow. The fetus is actually quite different, where blood coming back from the placenta in the lower body, which is connected in parallel to the lower body, comes back to the right side of the heart, and of the blood that exits the right side of the heart, most of it actually flows through the ductus arteriosus, so very little goes through the lungs. So preload for the left side of the heart actually predominantly comes from the umbilical circulation. So consequently, what happens when you occlude the umbilical cord at birth? if you do that, you get a sudden reduction in right ventricular output. The left ventricular output follows exactly the same path. So in this instance, this is in sheep, you get a 50% reduction immediately after you clamp the umbilical cord. You then aerate the lungs and you get a big increase in pulmonary blood flow. But some of you will be thinking, you're saying, hang on a sec, how can you get such a big increase in pulmonary blood flow when you've just told us that right ventricular output has dropped? And the reason for this is that very quickly after you occlude the cord, you get left to right shunting through the duct. So the left heart starts to contribute to pulmonary blood flow. And so if you do the calculations, up to 50% of pulmonary blood flow during this phase comes from left to right shunting across the duct. So what are the cardiovascular effects of cord clamping? Well, there's an immediate, very quick response. So as soon as you clamp the umbilical cord, you lose the placenta as a low resistance pathway for blood flow. And as a result of that, you very quickly, so this is heartbeat number, so this is 10 heartbeats here, within 4 heartbeats, you've got a 30% increase in arterial pressure, and because over this time frame, cerebral flow is also pressure passive, okay, you get a big increase in cerebral blood flow as well. So if you look at what happens, so you get this big increase in blood pressure, but because cardiac output is dropping, this quickly is restored. Heart rate drops quite quickly, and as I mentioned, right ventricular output drops. And it isn't restored until you start ventilation and you increase pulmonary blood flow at the same time. So you end up with this large fluctuation in blood pressure and carotid arterial flow. Now cardiac output is low until the lungs are aerated. So the question is therefore, so why don't you ventilate before you clamp the umbilical cord? So if you ventilate the lung, aerate the lungs, you decrease pulmonary vascular resistance before you clamp the cord, and you lose 50% of venous return. So if you do that, the first thing that happens is that, well, you get the actual increase in blood pressure and arterial flow as a result of clamping the cord is greatly mitigated. The reason being is that the lungs now become an alternative pathway, low resistance pathway for left ventricular output. And so, and this is via left to right flow through the duct. So you greatly minimise this increase in arterial pressure. And if you look at the other parameters, you see that you greatly mitigate these large changes in cardiovascular function at birth if you simply ventilate before you clamp the umbilical cord. So this brings us back to, I think, a really important point. So these are, many of you are probably familiar with these normograms which were published by Jennifer Dawson, showing the normal heart rate patterns after birth. And these are normal term infants that are considered to be normoxic. So they have a low heart rate initially and then increase. Now traditionally we're all thought to assume, well, this is actually bradycardia. Well, if they're bradycardic, then they must be hypoxic or asphyxic. But what I'm suggesting to you, perhaps, well, then maybe they're bradycardic because they have poor venous return. And this is the main reason why they're bradycardic and they're not hypoxic. But the main message here is that a bradycardic infant at birth is not necessarily asphyxic. It could be just lacking a bit of preload. So we've termed this, rather than delayed cord clamping, which you might be more familiar with, we've termed this physiological based cord clamping, and where you're actually determining the time of umbilical cord clamping based on the physiology of the infant rather than on a set period of time after birth. So increases in pulmonary blood flow before the clamp the cord replaces umbilical venous return as the primary source of preload immediately, which stabilises left ventricular output, but in so doing and avoiding those large fluctuations in pressure and flow may reduce the risk of IVH. And this might be the reason why delayed cord clamping leads to a reduction in IVH. It's also been reported that it increases placenta to infant blood transfer, and I just wanted to spend the last 5 minutes of my talk here focusing on this, because this is probably what most of you will be familiar with in terms of why you would do delayed cord clamping, because it increases the transfusion of blood out of the placenta into the fetus. And this all stems from basically from these studies that go back into the 1969. So here's the study here. It's done in Sweden, and what they showed is that over a 3-minute period, so delayed cord clamping over that time, there's this time-dependent increase in blood shifting from the placenta into the infant. And I have to say, I don't quite believe this data. I think there's some questions to be raised. I mean, the errors are incredibly low, but the concept that blood will shift from the placenta to the infant in a time-dependent manner, I think it sort of ignores a lot of what we know about the fetus and what regulates the fetus. I mean, we've known for Harvey that we're actually, the circulation is the circulation, so blood circulates. So unless there's a dramatic change in the compliance of the circulations, then the blood flow in should equal blood flow out. And to illustrate this point here, we can sort of divide the circulation up into a series of compartments. And so we've got one compartment here is the placenta. Here's the compartment of the second compartment is the infant and the infant body. But the third compartment we have to think about is the chest as well. And blood flowing in through the umbilical vein and artery, okay, there's going to be influenced by many, many factors. And you can immediately see that if you decrease thoracic pressure, then you should increase umbilical venous flow and decrease umbilical arterial flow as a result. And so just breathing and inspiration should affect this transfusion. Likewise, increases in intrathoracic pressure due to intermittent positive pressure ventilation, or even if the baby cries, it will pressurize its chest and abdomen, which potentially should shift blood, or either stop blood moving from the placenta to the infant, or even shift blood back into the placenta. Decrease in pulmonary vascular resistance just in itself by left to right shunting may also alter this distribution of blood between the two. So I think it's a very complicated procedure, and there's other things like oxytocin and gravity will also have an effect. So what we decided to do, and again when I say the royal we, this was a study that was done in the Netherlands by A. de Pas, where we just decided to look at blood flow using ultrasound in the umbilical vessels in infants that had delayed cord clamping at birth. So this was a prospective observational study of 30 infants. They're all vaginal births. Syntocinon was administered at birth, and I think it's an important thing to recognise. So they measured umbilical artery and venous flow using Doppler. And what did they find? Well, in 10% of infants there was no flow, and 57% of infants flow ceased at 4 minutes 34 seconds. It's sort of a little bit longer than what most people assume. 33% flow continued at least out to 5 minutes. What happened to the umbilical artery? 17% no flow, 40% flow ceased at 4 minutes 22, 43% flow continued. But the really interesting point here is that flow ceased in the umbilical vein before the umbilical artery in 8 of the infants. This is by 1 minute. But there's also infants where it ceased in the umbilical artery before the umbilical vein. So you can see there's a lot of variation here. But if it actually ceases in the umbilical vein before the umbilical artery, then there is a potential for blood to actually net blood transfer from the infant back into the placenta. And so if you look at some of their flow patterns, what they found was, most notably, that umbilical venous flow almost exclusively occurs during inspiration. So here's one of the flow patterns here. So this is flow, so this is inspiration here, and then stops, inspiration, stops, inspiration. So they showed it was very, very respiratory pattern dependent. Deep inspiratory efforts greatly increased the flow, as you can see here, deep inspiratory efforts. But it can flow, its flow can cease and it can reverse during crying, as you can see here. So here's the flow stopping and reversing. If you look at umbilical artery blood flow, they showed that at times it actually can be bidirectional. And when we first looked at this, we were quite confused as to why it would be bidirectional. But now I think we've got good animal evidence to show that actually this bidirectional nature here, it occurs inconsistently, but it predominantly occurs during a uterine contraction. So what we think is happening here is that when the uterus is contracting down, umbilical arterial flow is greatly reduced, and it becomes retrograde during, particularly during diastole and it's flying back into the infant. So it's also influenced and can stop during the infant's crying. So I think, you know, when we've actually looked at this, and I don't have enough time to show you all of the data, but all of these factors affect flow in the umbilical vein and cord after birth. And the one thing that we actually found that doesn't affect it is gravity. And in our experiments, it doesn't matter whether the lamb, in our case, is above or below or at the same height as the mother. Sure, it does affect flow, particularly in the umbilical artery, but the flow, the reduction in flow is if you have the lamb above the mother or below, the changes in flow are exactly the same in the umbilical artery and in the umbilical vein. So this is also consistent with the trial that was done by Nesta Bain, showing that the position of the newborn baby for cord clamping does not seem to affect the volume of placental transfusion. So, in summary, the fetal to neonatal transition is a sequence of interdependent physiological events. The primary trigger is lung aeration, which then stimulates an increase in pulmonary blood flow, and that in turn triggers the cardiovascular transition. It's influenced by labour and mode of birth, particularly the lung liquid clearance part, and it's also influenced by clamping of the umbilical cord. So I'd just like to finish by thanking the teams. There's a big group of people who have been working on this, and in particular Ian Pass, Graham Polglaze and Peter Davis. They've all been fantastic collaborators. So thank you very much for your attention.